Oh, we're going to start now.
I'm ready when you are.
All right. So this is a presentation by Dr. Richard Mann. Richard Mann is an American podiatric physician and surgeon whose career has spanned more than 4 decades, with a primary focus on understanding and treating peripheral neuropathy and disorders of the lower extremities. He's known for introducing benfotiamine, a breakthrough nutrient for the treatment of alcoholic and other peripheral neuropathies into North America and other regions. Today, his benfotiamine-based treatment protocols are implemented by thousands of physicians across the United States. As the founder and chief scientific officer of Realm Labs, LLC, Dr. Mann leads the development of clinically focused nutrition formulations aimed at improving nerve function, preventing limb loss, and addressing neurodegenerative conditions. His work integrates biochemical research, real-world clinical data, and applied therapeutics to help clinicians achieve better patient outcomes. Dr. Mann has lectured nationally and internationally and has written extensively on peripheral neuropathy, polyneuropathy, diabetic pathobiology, lower limb amputation prevention, and neurodegeneration. He is widely sought as a consultant by physicians, health systems, and industry partners. He also authors a respected physician newsletter read by thousands, which provides timely, practical insights into neurological disorders of the lower extremities, diabetes-related complications, and emerging therapeutic strategies. So with that in mind, Dr. Mann, I think you're going to be the presenter, and Annie's going to make that happen now. Annie, can you do
All
that?
set, Ann?
Yeah, we can see his slide already.
Okay,
Okay.
so let me see. So
Hey,
I just go over to my slides,
Mhm. Yes.
yeah.
presentation.
Yeah, you can
That it?
start
Let's see.
talking.
Where's my presentation?
Yeah. Okay, so Dr. Mann, I
Okay,
think you're on.
so this is it. Are we good?
Okay, we're good to go. Let's listen to you and you can click through your slides as you talk.
Okay, well, I want to thank you for having me here. I thank everybody involved in the Alliance for Addiction Solutions, especially Dr. Pierce, who asked me if I'd give a presentation. Thank you so much. You should know a little bit about my background. I'm a podiatrist, a foot doctor. I specialize in nerve problems of the feet and legs. I have I do not have extensive knowledge of addiction medicine, but certainly the adverse effects of addiction are always showing up in podiatric offices because of peripheral neuropathy, which is commonly induced by alcoholism and excessive drinking. And That is something that I've observed personally. About 20 years ago, I developed a product that in the US that was really used internationally called benfotiamine. I brought it into the States, did some studies on it, and made sure that it was safe, started using it, and primarily we were addressing diabetic polyneuropathy in podiatric offices. We did very well. We had some really great success, and along the way, we discovered it worked for alcoholism and peripheral neuropathy and also some central problems associated with alcoholism and the brain. And these studies have been coming out as we've been commercially involved in selling the products. And I've been studying it, and that's what I'm going to present to you today. Um, and a financial disclosure statement. I am the CEO and founder of Realm Labs, and we basically have Realm Labs and Zobria Labs, the two companies that produce products with benfotiamine, which we're going to be talking about. Benfotiamine being a very strong vitamin B1 derivative. The Neremedy line of products are sold through doctors' offices to their patients. So many doctors want to go ahead and dispense product in the office to their patients. It's a very efficient way of doing it. Patient leaves the office with the bottle in their hand, And this company, Realm Labs, which makes these Remedy products that you see on the bottom, is designed for doctors who want to sell patients the product in their office. We have a second company called Zobria Labs, and Zobria is designed for people who want to buy online. So if you're a physician and you want to go ahead and have your patient use the product and you don't like selling products in your office, you can send your patient to the website on the screen here, zobria.com, and we can sell the patient the products on that website. So it's depends on how you like to do business and if we're comfortable dispensing products in your office or not. But we have the availability to accommodate you whichever way you want to go. So the first thing we're going to talk about is vitamin B1. Vitamin B1 is an extraordinarily interesting vitamin. As you all know, a vitamin by definition is a substance that you have to take from an outside source. You do not synthesize it in the body. You have to get it from an outside source, and without it, you die. So all vitamins are like that. Vitamin B1 is really very specialized in that it has some significant multi factorial, interesting actions that are essential for proper energy production and use in the body. So you can see on the top left, we look at glucose um, uh, used to produce ATP. The glucose goes into the mitochondria. It's converted to something called pyruvate, and it goes through the Krebs cycle, and ATP is the result of the actions of the Krebs cycle. And thiamine is essential for the functioning of the Krebs cycle. So I think there are 8 enzymes in the Krebs cycle, and 4 of them, including one of the enzymes involved in the pathway to enter the Krebs cycle from the cytosol, are all dependent on vitamin B1. So without vitamin B1, you don't get that energy. The enzymes that are involved, there are 5 enzymes involved that need thiamine in order to work properly. And an overview, it's the ones of important for this discussion are pyruvate dehydrogenase, alpha ketoglutarate dehydrogenase, and transketolase. Those are in the lower left. On the upper right, we look at the nerve function, and you see that thiamine or vitamin B1 is essential for the myelin sheath. It's important for nerve impulse conduction, supports neurotransmitter manufacture and synthesis, and it provides the substrate for the active form of thiamine, which is thiamine pyrophosphate. And its deficiency causes many problems including peripheral neuropathy, muscle wasting. There's Wernicke's encephalopathy, which is well known to be a thiamine deficiency issue. You have cardiac effects with wet beriberi because the heart needs energy at very, very high levels, and without appropriate ATP production through the Krebs cycle, you get high output heart failure. You also get general feelings of fatigue, irritability, poor concentration. Thiamine has significant anti-inflammatory and antioxidative properties. It's really quite a remarkable substance. And benfotiamine, which we're going to talk about later, you can think of it as a thiamine that is much more bioactive, and that has to do with the fact that thiamine, vitamin B1, is a water-soluble vitamin, and the benfotiamine is a derivative of that, and it's lipid soluble, it's fat soluble, so its absorption is significantly enhanced. And talking about absorption, thiamine gets into your blood via the intestinal lumen, which is over here. And you see these B1 molecules, and in order for them to get into the cells that line the intestine or the enterocytes, you need a transporter molecule, either THTR, that's thiamine transporter molecule 1, or thiamine transporter molecule 2. They are coded by these genes, SLC19A2 and SLC193. So these transporter molecules, these are proteins that are sitting at the junction of the enterocyte and the intestinal lumen. They grab thiamine molecules that are in the lumen, they transport them into the enterocyte, and later that the thiamine is then transported and goes into general circulation. So that's the way you absorb thiamine, this essential vitamin that's needed for life. and appropriate neurological functioning and cardiac functioning and other things, you absorb it by the transporter molecules that take the molecule from the intestines and bring it into the body. The issue with respect to this lecture is that alcohol disrupts the integrity or the ability, or the impairs the function of those transporter molecules. The ones that we talked about here, this THTR1, THTR2. So alcohol damages those molecules. Chronic use of alcohol leads to decreased thiamine uptake because the thiamine, those transporter molecules are damaged. It impairs the transport and reduces the availability of thiamine to the body. Downregulating of the thiamine transporters is a toxic effect of alcohol. It damages them. Excess alcohol causes decreased expression of these transporter molecules, decreased MRA levels at the genetic level, and suppressed gene transcription. So thiamine damages the body's ability to, I'm sorry, so alcohol damages the body's ability to get thiamine into the body. And the functional consequences of this is this reduced thiamine transport causes reduced intracellular thiamine. And that causes decreased activity in these enzymes, which the first two enzymes, pyruvate dehydrogenase, alpha ketoglutarate dehydrogenase, these are involved in energy ATP production in the body. And you want to keep them functioning as efficiently as possible. You can't do that with low levels of thiamine. The last enzyme there, transketolase, is part of a pathway called the pentose phosphate pathway, and transketolase is important for antioxidative effects and production of entities that are used to make DNA and RNA and other molecules. So the systemic effects of alcoholism would be transport impairment, damaging the peripheral nerves, the brain, the kidney. Those are all, and the heart, those are all tissues that need a lot of energy, and they're deprived of it when the Krebs cycle is not producing enough ATP. You see, you have a global thiamine deficiency in your body. It causes energy failure, axonal degeneration, demyelination, and mitochondrial dysfunction. So, with respect to clinical implications, you should be one of the points I'm trying to make here is that in alcoholics who are suffering from thiamine deficiency, it's not just due to malnutrition, although that is a factor. It's due additionally to thiamine transport, which is central to getting the molecule into the body. Higher doses of thiamine may be required, but still, if the transporter molecules aren't working properly, you have to go to really very, very high levels to get some sort of passive absorption. In general, what is a much better solution is an alternative delivery strategy, such as an oral thiamine form that's lipid soluble, fat soluble. When it's fat soluble, it diffuses into the cells, the enterocytes, and it doesn't need transporter molecules to work. So if you have a situation where the transporter molecules are damaged, and in this case we're talking about alcohol and its toxic effects on the gut, the best way of handling it, you can either give an injection of thiamine or you can give a lipid-soluble form of thiamine. And benfotiamine is the most studied. It's extraordinarily safe and works really well. Therapeutic considerations are the water-soluble thiamine requires transporters. The fat-soluble form of thiamine does not. Thiamine, alcoholism and excessive alcohol use damages transporters, and as a result, you want to use a thiamine lipid soluble analog, benfotiamine being the most used and the most studied and extraordinarily safe. And of course, in this world of addiction medicine, Wernicke encephalopathy is a major problem. I looked at a review of the literature, and this responds often to thiamine supplementation, vitamin B1 supplementation. Usually it's injections or intravenous thiamine. And I put this slide up only to show that dysfunction of the neurological system in the brain due to thiamine deficiency, which is a hallmark of Wernicke's encephalopathy, can be helped with IV thiamine. Also, this is a case study, additionally, just making the point a little bit more that Case of Wernicke encephalopathy is successfully treated with long-term high-dose thiamine. So in the early 60s, the Japanese took the thiamine molecule, found it in things like shallots and onions, and they developed a lipid form of it, something called an allithiamine. And the lipid soluble form that is the most commonly used that was developed back in the 60s was benfotiamine. And you can imagine how safe this is, that this product has been around since the 1960s and it's currently being used. I've had experience with benfotiamine for about 20, 22 years now. I have extraordinarily a large number of customers, doctors who sell it to their patients, and we don't have any adverse effects. This is extremely safe. One of the things about benfotiamine, in addition to its safety level, is it works rather rapidly. It works in about 3 to 4 weeks. We're talking about in many types of neuropathies, including alcoholic neuropathy, which is, by the way, the second most common neuropathy, the first most common being diabetic peripheral neuropathy. And you can see that benfotiamine is absorbed passively as opposed to needing active transport. And thiamine, it's got greater tissue penetration, up to 5 times more thiamine gets into your body using benfotiamine as opposed to water-soluble thiamine. And it's really a preferred oral therapy for chronic alcohol-induced and diabetic neuropathy. It increases the thiamine pyrophosphate levels. And if you remember from your basic biochemistry, thiamine pyrophosphate levels that's the active form of thiamine that works as a coenzyme. Unlike water-soluble thiamine, benfotiamine is absorbed passively. That's the main point I want to make. It's independent of the gut transporter. So if you have a thiamine deficient state, you can go ahead and reverse it with a pill in which the thiamine has been made into a lipid-soluble form. Once it's inside the cell, it's converted to its active form, TPP, and you get up to 5 times the level of thiamine, and it's highly superior in treating chronic alcoholic neuropathy. This is a study that was done a long time ago in 1998. It's out of Germany. They looked at benfotiamine and the treatment of alcoholic polyneuropathy. They had an 8-week study. They had benfotiamine, they had placebo, and then they had benfotiamine with B6 and B12. Remember, benfotiamine is a vitamin B1. And it turns out that benfotiamine led to significant improvement of alcoholic polyneuropathy. Vibration perception, which is measured at the tip of the toe and is a marker of neuropathy, was significantly improved by the benfotiamine, and as motor function also was improved. The whole range of symptoms of alcoholic polyneuropathy were helped. And let me define terms here a little bit. Polyneuropathy means it's what alcoholics have. It's a bilateral symmetrical dysfunction of the nerves to the feet and legs. It starts in the toes and goes up the feet and legs. There's symmetry there, and that's the proper term for what alcoholics undergo. Unless it's a traumatic event to a nerve, then it would be a peripheral neuropathy. Peripheral neuropathy is defined as any dysfunction of the peripheral nervous system, and polyneuropathy is that form of peripheral neuropathy. We have this bilateral symmetry that ascends up the feet and legs in the stocking glove distribution. Polyneuropathy is far and away the most common type of peripheral neuropathy, but compression neuropathy is like what the chiropractors see, or tarsal tunnel syndrome or carpal tunnel syndrome or sciatica. These are compression neuropathies. They're polyneuropathy. They're a peripheral neuropathy, but not a polyneuropathy. So there was a tendency in this study towards improvement, was evident of pain and coordination. No therapy-specific adverse effects were seen. And that's a point I want to make. This stuff is extraordinarily safe. There are some other studies that were done in the literature. This one is out of Russia, and they used 450 milligrams a day. The other study used 600 milligrams of benfotiamine a day. They had good results. This is also an article in German, and it showed that it was very emphatic that you should use benfotiamine in treatment of uh, people with alcohol use disorder. This study came out of the States. It was done by this group headed by Dr. Manzardo. It's rather interesting. They took a look at 120 people who were actively drinking, and they gave the men and the women benfotiamine to see how they would react. And benfotiamine supplementation of actively drinking alcohol-dependent men and women was well tolerated. And they found that it may discourage alcohol consumption in women. So the thought is that the brain is working more efficiently because when you give the benfotiamine, you restore thiamine levels, and this allows the people who are taking the product to possibly control their use of alcohol. You can take a look at this graph from the study, and we're only looking at females because there was really no significant effect in males in the first study that they published, and you can see that females reduced their alcohol use with benfotiamine significantly as opposed to those who were taking placebo. And this is a chart looking at drinks per day. We use the benfotiamine versus placebo over up to 6 months. And you can see it's rather successful in that, which is rather remarkable. The same group went ahead and looked at the study again and re-examined the data they got. And this time they looked at men. They looked at because there were no changes, as you saw before, in males in their consumption. But when they looked at men and they looked at changes in psychiatric symptomatology after the use of benfotiamine, they found something rather surprising, which was that benfotiamine appears to reduce psychiatric distress and may facilitate recovery in severely affected males with lifetime alcohol dependence and should be considered for adjunctive therapy and alcohol rehab. Both studies found benfotiamine to be safe, well tolerated, with no serious adverse effects. So you're looking at an extraordinarily safe agent as a matter of fact, in the animal studies that were done in Japan in the 60s, benfotiamine used in very high doses was safer than thiamine or vitamin B1, which is water soluble. So it's extremely safe. And in full disclosure, there are studies out there looking at alcohol-related peripheral neuropathy, whether it's nutritional, toxic, or both. This is a study out of Brown University, and it showed that there is a toxic effect that happens with alcohol related peripheral neuropathy, and it should be looked at, but in the end result, the toxic effect has the effect of reducing thiamine transporters. So you're looking at a toxic effect on these thiamine transporters in the gut, and the way in which it is successfully or can be treated. And nobody's talking here about cures, but some treatment would be with a lipid-soluble form of the vitamin, the most well-studied, safest that we've been able to find, being benfotiamine. And this is a case presentation that I'm going to go through that is a patient that I saw a number of years ago. He was a 77-year-old white male presented with a complaint of burning, tingling, and numbness to his feet bilaterally. So that's a classic, that symmetry, that bilateral numbness, tingling, and burning is a classic sign of a polyneuropathy. The most common cause of polyneuropathy being diabetes. The second most common cause of polyneuropathy being alcoholism, alcohol-induced peripheral neuropathy or polyneuropathy. I should mention also that many times when a patient comes to you and you don't know why they have the polyneuropathy, it's often because they have alcohol use, excessive alcohol use, and they're not claiming it, which is very common. And also people who are in the category of pre-diabetics, in other words, people who are going to become diabetic, their hemoglobin A1C is elevated, not to the point where they would call them a diabetic. These people also have a very high number of people, about 20% of them have present with polyneuropathy, get polyneuropathy. He had a history of alcohol use disorder. He claimed in the past he would drink about a half a bottle of scotch every day and did so for a number of years. He claims he currently drinks 3 ounces of alcohol a week. I suspect that is I question that, but nonetheless, that was he said. He had a series of B12 injections in the past, which were not helpful. And B12 injections likely wouldn't be helpful unless he had B12 deficiency, and this gentleman did not. He was unstable with gait. He had pain in the balls of his feet and his legs. They ached continually. The symptoms have been present for many years and have progressed over the past 5 years. He requests treatment for an ulceration on the to the left second toe, which was a result of his numbness in the feet, secondary to the peripheral neuropathy. He healed well from the treatment for the ulceration. His medical history is positive for atrial fib, OA, and chronic pain, OA being osteoarthritis. Surgical history was positive for hernia repair, knee repair, rotator cuff repair. His medications were as Xarelto, Prilosec, Simvastatin, finasteride, atenolol, tramadol, Percocet, and potassium. He has no history of diabetes. Physical exam showed he had decreased sensation of the feet bilaterally when challenged with a 10-gram Semis-Weinstein monofilament. So one of the ways you can tell if someone, you can document that someone has decreased sensation is you put a fiber on them which bends at 10 grams. So you know you're keeping a constant pressure of 10 grams in one spot, and you see if they can feel it at different parts of their feet. This gentleman felt 4 of 10 spots initially. He really didn't improve much as we treated him. Physical examination didn't change much, but his perception of pain and his perception of well-being increased dramatically. He had absent Achilles and patellar tendon reflexes. Patient had significant difficulty determining temperature sensation to the feet and legs bilaterally. This is hot versus cold. Decreased vibratory sensation was noted to the feet bilaterally. And the dorsalis pedis and posterior tibial pulses, which were the pulses into the feet, were palpable. There was no evidence of ischemia or impaired arterial flow. After we started him on the remedy, 600 milligrams BID, within a couple of months, he claimed that he had 60% improvement in his neuropathic symptoms within 3 months. The reflexes never returned. He was, it's questionable whether he had any improvement in sensing Semis-Weinstein monofilament. I did not do an epidermal nerve biopsy on him. I don't like taking pieces of skin out of people with neuropathy or people who I have think may have issues healing. For those of you who don't know what an epidermal nerve biopsy is, when you have peripheral neuropathy, there's decreased density of epidermal nerves in the skin. You can look at that from a biopsy. That's a way of managing or monitoring whether or not there's any improvement in nerves. I didn't do that with him, and I didn't do it on purpose because I don't like it's an invasive test. And for those of you who are interested in learning more about benfotiamine, there's an awful lot of literature out there. This one was one of the first that came out that really looked at the incredible variety of anti-inflammatory, antioxidative, and other effects that benfotiamine has. We've had some success with central neurological diseases. There's a study going on and testing it on Alzheimer's. I've written a couple of papers on patients that we've observed with long COVID, with Parkinson's, with um, amyotrophic lateral sclerosis, who claimed that they had some improvement. You can look up the papers, they've been published. And so it seems as though benfotiamine has this effect of significantly improving nervous system function, neuronal function. This is a study that was done on benfotiamine in diabetic polyneuropathy, which is also often miscalled diabetic peripheral neuropathy, especially in the States. And we had some the group reported some excellent results. You can see after 6 weeks using 600 milligrams of benfotiamine a day, you had decreased pain, decreased numbness, which is really very important because that infers increased sensation. And increased sensation is very important to prevent ulcerations or wounds, or it significantly impairs lower extremity amputations because people who go into amputations generally develop wounds in their feet and legs. The wounds get infected, and you have to treat the infection. It's very difficult often because they very often have impaired immune function as well. So you want to get your patient into an environment, one, where they're not damaging themselves. So sure they're in a really good shoe. Make sure there's nothing in the shoe when they put it on. Make sure there's no seams. There are shoes that are made for people with neuropathy specifically, and you want to go ahead and have them inspect their feet on a daily basis so that if they do get an ulceration, you're able to address it immediately. The sooner you get to treat an ulceration, the more likely you are to cure it. There was decreased burning, and paresthesia were basically um, unchanged. This is a paper that was written by endocrinologists, and they talked about alcohol consumption as a causator and or accelerator of neuropathy in people with diabetes. How it's often overlooked. This group said they won't treat a patient with peripheral neuropathy if they continue diabetic peripheral neuropathy if they have any alcohol at all. We all know that metformin, which I'm going to speak about a little bit now, has a um, impairs vitamin B12 absorption. There's a study on that. And when combined with diabetics who are alcoholics, this is of great significance. If you have a patient with on metformin, they probably need some sort of B12 supplementation as well. This is a study, and the way metformin inhibits B12 absorption is it competes and inhibits the B12 transporter molecule in the gut. This is a study that is really interesting. It shows that metformin also competes with thiamine transport as well and is capable of decreasing thiamine transport into the enterocyte that we talked about before. So, as we said in conclusion, the we've been treating neuropathy for about 20 years, and currently we're in thousands of offices. The main product line we have is Neremedy, and you can reach us at 561 or online at neremedy.com. And this is the product we use for doctors. When doctors want to resell or dispense in their office, they use this product. It's got benfotiamine in it with various amounts of vitamin B12. And this is the product that has been highly successful. And a few years ago, we recognized the need for a direct-to-consumer product. And we named it, well, I named it Zobria. And that turns out after I named it Zobria, um, we're getting a lot of patients independently getting the product and having success. And it turns out that the phone number we got was this one over here, and it's Zobria T, which means sobriety. If you pronounce it differently, this could mean sobriety. So this is a sobriety promoting product. I think it's the work of Manzano talks about that and shows it, although nobody guarantees anything and we make no claims, but this will increase significantly the blood levels. And I thought it was quite serendipitous that the name of the product, Zobria, got an 8 at the end of it when I was getting phone numbers, and it could be pronounced sobriety. I thought that was rather interesting. I wanted to share with you. Thank you so much. My name is Dr. Richard Mann. If you want to contact me by email, you can call me. You can get me at realmlabs123@gmail.com. And now I'll open it up for questions. Do you need me to do anything?
No,
Okay.
I
Can you see
was,
me?
I can still see everybody. And when I've used this, I've used it on gabapentin, induced polyneuropathy, and it's worked surprisingly well. Um, has there been any studies on that
You
that
know,
you're
that's
aware of?
interesting you should mention that because recently I came across a study where they used benfotiamine and gabapentin in treating carpal tunnel syndrome. And the gabapentin the results were better with benfotiamine and gabapentin than gabapentin alone. You know, gabapentin suppresses nervous system function. And that is excellent. But if you have a nutritional element here, which is that you have decreased vitamin B1 levels, you probably would want to go ahead, as opposed to suppressing nervous system function, you probably would want to go ahead and give the nutrients that the nerves need to work more appropriately, and that's what we find. So gabapentin has a place, but if you have a nutritional issue, if it's a B1 deficiency, and you're looking at diabetics and alcoholics and diabetic and alcoholics, you might want to try a nutritional approach before you suppress the nervous system with an agent like gabapentin or Cymbalta or some of the other various agents that suppress nervous system function. Any
Okay.
other questions?
Yeah, T.G. Hirschberg is asking about, is there any comments on the thiamine paradoxical reaction? Yeah.
Yeah, I think you're referring to the paradoxical reaction that often occurs with another form of lipid-soluble thiamine. I think it's TTFD. And some have related it with intravenous thiamine. I see, we don't have that at all. To answer your question, I've never experienced that. We're talking about tens of thousands of people taking the product. No one has ever called and related that, no physicians. And it's even better history because they're from physicians. We don't have any, I don't have any physicians ever called about that. I think it may be that benfotiamine does not have that. I suspect you may be talking also about the work of Constantini, and there's a fellow out there, Elliot Overton. They talk about this. Constantini was a really interesting fellow, a neurologist. He's passed away about 4 years ago. He was giving thiamine injections for a number of neurological conditions, and it worked rather remarkably well, especially Parkinson's disease. So there's a lot of good that can be done with use of thiamine in neurological conditions. Benfotiamine appears to be the safest of all, and that's about all I have to say about that. Yes.
Thanks. Any other questions, anybody?
Yeah, I have a question about the B12, which is better absorbed sublingually, and it's included in the tablet, um, that first product you mentioned.
New remedy?
Yes.
Yeah. What's your question, ma'am?
B12 is generally given sublingually for better absorption. And this is part of, I assume it's a capsule.
Yes.
So I'm just wondering about the relative absorption of the B12.
Okay, that's a great question. So it turns out that vitamin B12 has in the past been considered a product that you cannot give too much of. There's a lot of people out there that get very, very high levels of B12 into their patients, and it's thought that if you have too much B12, you just urinate it out, and that it doesn't do any harm. And I'm not so sure that's the case. We've had a number of studies now that showed that super physiologic levels of B12, more B12 than is really needed, can cause significant medical problems, adverse effects. We're talking about increased, some people marking that there are increased levels of cancer when B12 is very high for a very long period of time. I direct you to a study called by FANIDI. And if you want, you can get in touch with me. I'll send you the study. There are a few other studies on that as well. And I think that B12 levels have been shown to work most effectively when B12 is put in the normal physiological range, which if you're running blood tests is 400 to 6 or 700 picograms per milliliter. And people are finding that when they give higher doses of very high doses of B12, like a milligram or two or three or 4 or 5, that vitamin B12 levels go very, very high, well over 1,000. And there's a question as to whether or not you're doing any harm to the patient. So I don't think the problem here is absorption. Certainly, sublingual absorption of B12 is superior to capsules when you take it in, but the problem is not getting B12 levels as high as you can. As a matter of fact, if you're dispensing B12, I would suggest you read the studies. I'll be happy to send them to you. And you might want to look at trying to keep your patients at a level. We have normal physiological levels as opposed to as high a B12 level as you can get. So yes, you're right. It's better absorption, but the question is, do you need better absorption? And I think the answer is you want to, if you're dispensing B12, you want to keep your patients in a range where you have no B12 deficiency, but not excessive B12, which may cause adverse effects.
Okay, thank you.
Dr. Michelle Perron asks, can it lead to burning mouth syndrome? I'm assuming you're asking, can this supplement lead to burning mouth syndrome? Supplementation with benfotiamine?
Can
I
high
think
serum levels of B12 be associated with burning mouth syndrome?
B12.
You
Okay.
know, I don't know. I think that it may be when you look at the adverse effects of high levels of B12, it's all over the place. But I have no reason to think that that's the case. I would be more concerned about impaired one carbon metabolism, which is something that's needed. One carbon metabolism is associated with cell production and cancer. So, no, I do not know if high levels of B12 will lead to burning mouth syndrome. I guess you can investigate that. I don't know if I hear of anything. I'll get back to you. I've never seen that. We have never had anybody express that with the use of Neremedy. Benfotiamine certainly would not impact that. I'm assuming you're talking about B12. So, but if you're using B12 to treat people, you want to go ahead and apprise yourself of the latest in the literature. And this is not something that is uncontested. But there are a couple of very good studies out there showing that high levels of B12 can cause damage. And you want to keep your patients in a range where it's healthy, where there's no deficiency, but not so high that you would get adverse effects. In the US, we measure B12 in the serum by picograms per milliliter. And you want to try and keep them about from 4 to 600 or 500 is an ideal level in the serum.
Okay, thank you. I have a client with high levels at 919 picograms. She does not take B vitamins. She has a history of fatty liver disease, which seems to have resolved. A1C is on the high side. So we're just trying to figure out a little more in depth about where this might be coming from. So I'll keep reading.
So no, also, so your patient who has hemoglobin A1C that's on the high side and they have burning mouth syndrome, my first thought would be they have a diabetic neuropathy. And the
Yeah.
diabetic neuropathy can express itself in many ways, but you certainly can get burning mouth syndrome from it. This patient should be treated as though she has diabetic neuropathy, and in my opinion, the treatment of choice, the initial treatment of choice, is the benfotiamine. So
Yeah.
those are the
See, I knew
thoughts
there
on
was
it.
a link. I knew I came today on purpose.
Well, let's hope serendipitously you and I make this patient's life a better place and we help her. Certainly, what I like about the product is there's no adverse effects. You can't hurt anybody. So, if you want to get in touch with me, you know how, and I'm happy to talk to you about the case. But yes, what you expressed that she's got an elevated hemoglobin A1C, 20%, that means unless she's past the point where she's a diabetic. If she's a pre-diabetic, which means
Mhm.
she goes right up to the border of where diabetes is defined. If she's a
Yep.
pre-diabetic, our studies show that 20% of pre-diabetics have some sort of neuropathy. So that would be my suspicion, although tough to make a diagnosis over the computer talking to you.
Yeah. All right. Thank you.
Sure, my pleasure.
Yeah. Jan Patrineau does make the comment that burning mouth is typically a low B vitamin syndrome, which is Also, as another nutritionist myself, that's often what I see as well. So, but TJ Hirschberg has a question. Are you aware if there are any indications that GLP-1 agonists like Ozempic affect B12 absorption or negatively affect nerve health?
I have no idea. I mean, you can look that up nowadays. It's, that's an inquiry into an AI program, but I have no idea about that. I have not studied that.
Yeah. But it's certainly timely. It's that Ozempic is suddenly selling tremendously. So another question was, do you have any comments on B6 supplementation or inducing neuropathy?
From what I understand, you have to have rather high levels of B6 to induce neuropathy. B6 is often used to treat neuropathy, and then people get exuberant in their usage of it. They go to very high levels. I would supplement them with what is recommended. I wish I could say to you that in all the 40 years I've been treating, I found one or two people who actually had a vitamin B12 deficiency. They presented with neuropathy. We did the blood work. They were low. They got significant improvement. When you augmented them, I had no one with B6 deficiency that I noted. Doesn't mean it wasn't there. I certainly could have missed it. But I would be careful with giving too much B6. Some of the studies that were talked about show that excess B6 can be harmful. So I'd be careful about how much I would give.
As a clinical history nugget, I actually did have patients who had taken like 500 milligrams of B6 for prolonged periods of time, and their presenting symptom was usually burning of the feet, sometimes burning of the hands. And I would get them down to normal levels of B6, and those symptoms would go away. So that became my, does this person have burning feet syndrome? How much B6 are they taking? Became a normal question in the history.
Yeah, I think in the past I mean medical professionals have been very cavalier about giving vitamins out. The thought
Hmm.
being, there be vitamins, you urinate them out if there's too much, but that's not turning out to be the case. And I think you have to be very careful about what levels you give to patients. From what I can see, you certainly can have harmful effects from B6, and we're talking now, well, you could have harmful effects from excessive B12. We haven't found any of that with B1, but I think if you're prescribing or dispensing this stuff, you need to monitor them and see where your patients are at.
Are there any other questions? Well, Dr. Mann, thank you very much for this. This has been enlightening
I'm
and
glad to have
very to the point as well.
well, thank you so much. I thank you again for the invitation. It was an honor and a privilege to be able to give this presentation. Thanks to everybody in the audience for listening. And if you need to get in touch with me, that's the email address. Happy to speak to you about a case or in general, or if you want to dispense it in your office, or if you have patients who you want to contact me and buy it specifically. So thank you very much, and everybody have a great day.
Thank you.
Thank you.